All right. So Northwest Ohio EMS guidelines, basically for the St. Vincent's Island ambulance. You guys are under the direction of the Northwest Ohio EMS Consortium, and there's a couple doctors, myself, Dr. Newmeyer, which you guys will potentially meet in the future, and then Dr. Matthew White, who works at Wood County Hospital and all that stuff. So the three of us together are the med directors, kind of sort of helping out. Myself, Dr. Newmeyer still fly, so you guys potential with Life Flight will see us and all that on there. The guidelines, and Greg can show you, are there's an app that we've created. Actually, we've purchased. It's the PPP agency. So for your iPhones, Androids, and all that stuff, you can download the app. I'm still waiting. The current version for the guidelines will be a 2013 version if you download it right now. I've sent everything over to the gentleman in California to get it updated, so I'm hoping within the next week the new version will be on the app and all that stuff. How the guidelines is set up for those that as a first time, it's a 9 tabs. With the first part being the operational, tab 2 is all the cardiac, tab 3 is the adult medical, tab 4 is the OB with the neonatal resuscitation, 5 is the pediatrics, tab 6 is the environmental, 7's trauma, 8's medical, and then 9 is all the medication. We do allow you guys on the island to perform medication-assisted intubations, and I know when Tim and Pat get there this afternoon, along with Greg, we'll be really going down the guidelines, protocols for the medication-assisted intubations and all that stuff. So just to really make sure that you guys know that information. Okay. First part, just the scope and purpose, kind of sort of why we do this. We changed the term from protocols to guidelines this past go around, and it's really from the aspect of with protocols, the intentions are always you must do the X, Y, and Z, versus guidelines. These are more scientific based and all that stuff, and we know that each thing is not specific, so you can't say, you know, every person fits into a specific protocol, so that's why we went with guidelines. Now, of course, I have one simple rule number 1, which is what?
Yeah, record.
Okay, thank you, you guys remember. All right, so rule 1, keep me out of the courtroom. That's all that I ask. So with the guidelines, even though they're not protocols, I still have a strong suspicion and all that stuff, or I still adopt the policy, don't go off the reservation. You know, from the aspect within the fire, you know, the fire scene and all that stuff, where we're taught no freelancing. Okay, if you work within the guidelines, you do your job, you keep me out of the courtroom, I will protect you. Now, if you go into way left off, you know, into left field, and you're doing something that's not within the guidelines, if you can justify it, yeah, I'll protect you. But if you have no justification in the science is not there, you know, I can't protect you. But I will, you know, that's our job and all that stuff. All right. Tab 1, operational. Just kind of sort of going through things. From the aspect of who we are, there is the website the www.nwooems.com that has all the information, talks about the join.me, the trainings and all that stuff. There will be a video on the website for the spinal mobilization guidelines. We'll touch upon it a little bit later tonight, but want everybody to actually go through and watch the video, which is going to be an important thing to kind of sort of talk about how we do the cervical mobilization and or clearance and all that stuff. The rest of tab 1 is just the aspect of guideline specific stuff, patient information, who's intoxicated, which you guys will do a lot of intoxicated patients out there on the island. You'll become experts, so the masters of determining what to do and how to do that. From previous or from last year's and all that stuff, and under the policy, changed it up from the aspect of expectations. All providers, of course, should have an EMT, should have a BLS card, along with advanced EMTs should have a BLS. Paramedics should have your ACLS, your PALS, and then of course the BLS. I know that a number of lifelike people and all that stuff do have ITLS, which is recommended but not required. Is Julie requiring you guys, Greg, to have it?
Not ITLS yet.
Okay, so to be continued. The rest of the stuff in the guidelines and all that stuff is just what is the assessment, treatment, documentation. You guys will, of course, will be using EMS charts, which is a good thing. I'm able to get online and view and all that stuff. And the last piece is just the standard what every patient you should be doing and all that stuff. Tab 2 is just the scope of practice. Looking at, it's the April 16th of 2014. They keep telling me that it's going to be changing sometime in the near future, just updates, but still have not seen that update. I'm not going to read through the scope, let you guys, that's going to be your quiet time, 3 o'clock in the morning, nothing better to do reading. Documentation of vital signs is a new tab into the guidelines. Really from the aspect of the big 3. So your pulse rate, your blood pressure, and your respiratory rates. Expectation of these are manual. The first initial set of vital signs should be a manual set of vital signs. Of course, from the aspect of what we've been talking about over the past guideline reviews, okay, most of the respiratory rates that I see documented are 18 to 20, okay? What does that really mean? Well, most of the time it's a made-up number. No one actually really does it. Specifically when it comes to patients that have shortness of breath or something like that, make sure that you get a good respiratory rate. Nothing looks worse than giving a patient a breathing treatment and there's no respiratory rate on there, and or pulse ox. You guys have the equipment and the monitors and all that stuff, and we're actually trying to buy new monitors for you. Hopefully that'll come about sometime in the near future. Criteria for ALS, this is just a when the EMT should be contacting for ALS. With you guys out there having a paramedic or advanced EMT all the time, this isn't much for you guys. The big change, of course, is into the glucose. Before it used to be the 60 to 400. Now it's 60 to 250. Rest of that stuff is really unchanged and all that stuff. Patient disposition, from the aspect, I know that there's going to be some potential concerns in the future, and I know that Greg was talking about that with the quote-unquote clinic that will be out there. My opinion is it's really going to be the aspect, yes, it's going to be a clinic. Your unstable airways, your STEMIs, your strokes, and all that stuff. I don't care what that doctor says. Those patients are going off the island and go from there.
That answers the question, Doc.
Yep.
Are we checking with that doctor on the med control, or is it still our discretion? Call for a bird.
It will be your guys' discretion. I don't care what that doctor has to say. It's from the aspect, if you got this is a trauma, this is a stroke, this is a STEMI, they're gone. I don't care what that doctor has to say.
Excellent. Thank you.
Yep. Of course, the rest of the stuff. I mean, if it's the non-emergent stuff, your slips, trips, falls. If you got you got a broken arm. Yes, all that stuff can go back to the clinic, and they can take care of that, and they can decide. So it'd be like those that work around the Mercy Perrysburg. you know, the Mercy Perrysburg ER and all that stuff. You're going to bypass, you know, for strokes. You're going to bypass for OBGYN and all that stuff. It'll be the same thing for you guys there on the island. Anything else? Any other questions? All right. The rest of the stuff here is, of course, is just a matter of documentation, patient transportation. Do have in here the no patient contact, no incident found. So occasionally you will get that, oh yeah, there's a huge accident or something. If you get there and you know they really didn't watch you guys, I'm okay with saying, okay, have a good day, and go from there. Appropriate transport. This is the majority of the places of where you guys will be sending patients to. Unfortunately, in the past, and we're still trying to work this with firelands from the aspect of taking trauma and or cardiac. It's just hard sometimes to get them to take things. So always remember from the aspect, St. Vincent's will be the default fallback for you guys. Air ambulance and mobile ICU and the Coast Guard, you guys will become a master of this. For those that haven't done this before, Greg will take the lead and most of the time in the activation of the helicopter if he's on the island, and or Dan or one of the other senior paramedics, kind of sort of going through the whole process and teaching and all that stuff. Do have in here sometimes the aspect that you can't fly. We have all the phone numbers for to get the Coast Guard out there in regards of calling for the Detroit controller group and then calling for the ship commander at Marblehead. Phone numbers. This is just the aspect of communications. If we need to get somebody in the regions, you have all the different phone numbers there. In the last, from the aspect of, well, I need to talk to somebody, but I don't want to talk with Firelands. I don't want to talk with Magruder. Okay. The med control at St. Vincent's will be your default fallback. I know that I get a phone number, calls from you guys all the time. So the 419-251-4354, that will be your fallback default med control. Call there, ask for an attending. You'll be put on hold for a couple minutes. You get that nice little music in the background. And then just explain who you are. They'll kind of sort of, and the biggest thing is when you talk with them, kind of sort of have a plan in mind saying, hey, I got the patient here that has the breathing problems, I want to do this, this, and this. And they be like, well, no, hold on, try this, and go from there. Or if you call there and you just don't know what to do with the patient, going, and be honest with them, going, hey, I got a patient that's crashing on me and I have no clue, intubated and going from there, birds en route, can you give me any other suggestions? All right. Any questions thus far? Anything else? Nope. Just got the birds chirping in the background, which I like. Literally, truly, birds chirping. Chirp, 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 chirp. All right. In the medical legal side of this, just remember from the aspect of mental capacity versus mental competency, okay? We do not deal with mental competency. We deal with capacity. So in mental capacity, it's really three things. Do they understand what's going on? Do they understand the proposed treatments? And then do they have enough emotional control to be able to take care of their own affairs? All right. If they don't have those three things, then we can, by law, take over as medical surrogates. All right. So sometimes, and this is going to come into play in a little bit when we talk about the altered mental status with naloxone use. So there's some changes going on with naloxone and all that stuff. Just remember consent over the age of 18 or 15 to 18 if they're emancipated, which I don't know many 15 to 18-year-olds that can actually survive on their own, but it's there. Aspect duty to act. We all have a duty to act and responding, and then confidentiality. Okay, if you have $100,000 to be able to do a HIPAA, okay, the federal government will be more than happy to take your money from you. Okay, I personally do not have the money, so I ask that you keep, patient information confidential. Okay. So the question is really, Doc, we got this run. It's a good run. I want to talk about it. What do we do? All right. Well, you pull everybody inside, you shut the door, you lock the door, and you call it peer review. Okay. Peer review is protected. It's protected by Ohio Law 4765.12. So as long as you do peer review, and then from there you talk about it in that peer review, the lawyers can't come and get you. The judge can't come and get you. Okay? And it goes back to rule number 1. You guys are keeping me out of the courtroom. From that aspect, once the peer review is done, you walk outside. You don't talk about the case anymore. That then becomes that can become discoverable and could be a HIPAA issue. All right? Any questions on that? Nope. Okay. Refusals, treats, release at the scenes. You guys will be doing a lot of this from the aspect of our the drug-enhanced individuals on the island. Or actually, it's chemically enhanced. And then from there, just the transports, refusal, release at the scenes. Ideally, if they're under the influence of alcohol or drugs, they can't make their own decisions. But if you have someone that can do that for them, they can be transported and released and all that stuff. Most of the stuff is just the third-party callers, special considerations, and all that stuff. Occasionally, and I haven't seen that much on the island in the past, and I don't know how this individual, the doctor in the clinic, how it's going to actually piece into this. But the conversations that have had kind of sort of, this individual might be going out and responding with you guys on some of the runs. That means that he can act as med control. Now, if it turns out that this person is a family practice doctor with no EMS experience, I'm going to really shy away from this individual giving you guys med control orders and all that stuff. If it's someone, an ER doctor, yeah, no problem. Nurse practitioners, physician assistants, I'm sorry, still fall under the category like with nurses, where in my opinion they don't have any real authority of medical control and all that stuff. Some try, but again, if they have no knowledge of EMS, I don't want them giving you guys med control orders and going from there. All right. Questions on that? All right. Infectious control, just again, wear your goggles, wear your glasses, don't take the crap home with you. That goes through all that stuff. Controlled substance. Greg will again go over the policy with you guys on controlled substances. This will be a surefire way if you have any issues with this of getting into a real deep hot seat, both with Greg, Mercy, and then also with me and all that stuff. The DEA will also, they frown upon that. And then the final guideline is just the practitioner disciplinary policy. This kind of sort of goes through the aspect as EMS providers. The initial thing, this is the law part of it that says that you guys have to have a medical director. From there, it goes through the rest of it of why we're doing what we're doing in regards to disciplinary. Yes, you guys do go through the potential of HR as a paramedic. With Mercy, the EMTs and advanced EMTs, of course, you guys are employees of the township, so you'd go down that pathway. If there's a big issue, of course, Greg is involved. He talks, If there's something that I have to be involved with, you give you guys a couple days to kind of sort of respond of what's going on. We sit down and talk. If you don't like what happens, then we come back in a couple days for another meeting. And then we kind of sort of figure out what we're going to do. It could be a matter of no action versus remediation versus temporary suspension. And if it's really gross and heinous, of course, the permanent suspension. And the philosophy, of course, if you're removed from the guidelines or from the drug list and all that stuff from one department or jurisdiction, then you're removed from all departments, jurisdictions within the Northwest Ohio EMS. All right, now to the final. Universal patient care. All the rest of the guidelines and everything stems from this piece here. The scene safe, universal precautions, the established responsiveness, your EMS assessment, any of the airway procedures, your vital signs, and then all the additional therapies and treatments and all that stuff. Of course, it does have in this, I didn't change that, I need to change that. Go to the appropriate guideline. No longer protocols. Questions on tab 1?
No.
All right. Tab 2, the most of the part in the cardiac section and all that stuff is really unchanged. The biggest, of course, is all the AHA when it gets down into the ACLS and PALS and all that stuff. Otherwise, I mean, if you know your AHA, you can run a code and go from there. In the chest pain, kind of sort of, your EKGs, given the aspirin, nitro, appropriately. The next drug after your nitro is going to be going into more of the midazolam. Really liking Versed from the aspect of trying to calm a patient down. If you guys remember back to your paramedic anatomy, physiology, and all that stuff, you know, the heart rate is dependent strictly on oxygen, or actually oxygen dependent on heart rate. You increase the heart rate, you increase the oxygen demand, and that's what worsens or causes problems with the STEMIs. So if you can calm them down, give them a little bit of oxygen, you can decrease their oxygen demand, which in turn you can de-evolve a STEMI. Okay. For the advanced EMT, okay, yes, Zofran is only sublingual in PO. All right, that is a new change from the guidelines a year and a half ago. They did not, the Board of EMS felt that since you cannot interpret an EKG, you can't interpret if the person's having QT prolongation, thereby they don't want you to give IV medications. Rest of that's just the declaring the STEMI, calling floor flight and all that stuff. CHF, CPAP, of course, is the mainstay therapy. IVIO access, nitro. If the person's having problems with the CPAP, they can't tolerate it, of course, giving them a little bit of midazolam. Enalapril is the next drug for the paramedics. And then if you guys, and you're not carrying Lasix out there on the island, are you, Greg?
Yeah, we are.
Okay. If you're 30 minutes into nitro, and usually if you're giving the patient 5 sublingual tablets of nitro 5 minutes apart, so 15 minutes, you're at about 40 mics. So from that aspect, if you're still popping, having them still pop the nitro, and they're in CHF, then the helicopter is not flying, you're having to wait for the Coast Guard, then of course consider using the Lasix and all that stuff. Cardiogenic shock, not much has changed with this one. Of course, the biggest thing therapy-wise is going to be either your norepi drips or your dopamine drips. And then if they're still profoundly hypotensive, going into the epinephrine drips. So if you've never made an epi drip, it's actually very easy. Take a liter of IV fluids, take your 1 milligram of crash cart epi, shove it inside, and you now have a 1-to-1 concentration of epinephrine. Or you can do in a 500 bag, you get a 2-to-1. If you throw it in a 250 bag, you get a 4-to-1 concentration. Okay? And my philosophy is titrate for effect. If you have access to a pump, great. If you don't, open it up and get a blood pressure. Cardiac arrest, very little has changed with this one, except I'm just going to skip down to the next page. Most of the stuff that we do here, and now that you guys have the Zoll Auto Pulse, this will kind of sort of help change the way that you guys manage the cardiac arrest. Of course, Greg will be able to educate you guys since he is a master of the Zoll. And for the training and all that stuff. Most of the time, though, if you don't have the Zoll, if it's on another run or something like that, really work the patient where the patient fell. Okay, work them for 20 minutes, have flight coming, and then kind of sort of transport from that aspect. If the patient's in a PEA or an asystole, flight usually will not fly that patient. Just take that in considerations. There is some therapies coming out right now. We haven't adopted them into the guidelines as of yet, with the aspect of the cerebral resuscitation. So they're kind of sort of going down the pathway of thinking for the first 6 to 8 minutes of a code, you do nothing with ventilations. It's all about chest compressions. Rate of 100, turn the metronome on, and it's all about CPR and perfusion, okay? Part of the thought and theory is going down that once you start ventilating, you decrease preload coming back to the heart, which then you decrease the perfusion potential going on. So if you didn't intubate for the first 6 minutes, I'm okay with that. Just throw a high flow non-rebreather on them and go from there. Questions on that? Okay. Medication-wise, in a cardiac arrest, I really don't care what you guys give. Most of the medications out there don't really do much of a benefit. Epinephrine, if you look at the literature-wise, you have a 50% increase in return of spontaneous circulation, but the actual having the patient walk out of the hospital, there's very little benefit. Vasopressin is no longer being manufactured. So if you don't have vasopressin as your first line drug, that's fine. Just use epinephrine and carry on. And remember, with mothers, maternal arrest and all that stuff, got to take care of mom, and she'll take care of the parasite inside of her. PICR CPR in Guideline 5. It's been adopted several years now, been working. And it's really just from the aspect of kind of sort of having a standardized way of doing things instead of everyone stepping on each other. So if you get down into the triangle, remember from the aspect within the triangle, it's all BLS, okay? We as paramedics, even myself, unless you're doing chest compressions, you should not be inside the triangle. Drill the patient into the tib or in the femur, push all your medications from there, throw the patient on your, again with the Zoll, a lot of that's going to be changing, okay? But really from the aspect, it's all about, the BLS inside the triangle. And go from there. Hypothermia, nothing really changed. Patients are dead until they are. Yes. I didn't change that over. I need to change protocols. Ha, crap. Alright, gotta do some changes on this. From here, warm and dead and all that stuff. Traumatic arrests, from this aspect, nothing has really changed. We'll have some additional things when we talk about the termination and resuscitations and all that stuff. I still do have the underlying notion. If you have a true traumatic arrest, the kind of sort of from the aspect, I know this is probably a little bit morbid, but if the patient walks out of the hospital and it was a true traumatic arrest, I'll buy you dinner. I'm still leading right now for the past 3 years. It hasn't happened, just because of knowing that most traumatic arrests, they don't survive.
All in how you document.
Yeah, exactly. Well, true. It has to be a true traumatic arrest, though. Asystole PEA, nothing's really. Just remember from the aspect of your H's and T's, and then treating and going from there. On the VFib VTech, again, this is just all your AHA stuff, your epinephrine, vasopressins, which again we don't hardly have the vasopressin. So if we don't go there, we don't go there. Amiodarone, both for your adults and the peds, and then down to the mag sulfate, and then transporting. Do have in all the previous guidelines that used to be for the hypothermia, or consider hypothermia, which have changed that over to the post-cardiac arrest guidelines, which we'll get to in a second. Post-cardiac arrest guideline, like I said, from the aspect if they're, make sure that they have an airway, make sure that they have the additional IVIOs, and then treating EKG, STEMIs, and all that stuff. If there's over the age of 18, of course, the aspect of the therapeutic-induced hypothermia, which is the next guideline, and then any of the hypertension, norepi's, dopas, and all the other guidelines. In the therapeutic, of course, from the aspect of packing or exposing the patient, in the past, we've always been taught about giving, packing ice in the axilla growing and behind the neck. There's some literature that came out about a year and a half ago from the Air Force, where they're saying putting ice packs on their palms of the hands, the soles of the feet, and then on the cheeks, actually has an increase, or an increase in the reduction of their temperature over the growing, the neck, and the axilla. So take that in consideration. I guess our opinion now is just throw the person on ice and go from there. We still are doing the 30 mLs per kg of chilled saline if we have it. If we don't, then go from there. Otherwise, fentanyl etomidate. If the person is shivering, we know that's a bad thing, so give them the midazolam for sedation. And of course, if you have to paralyze them, paralyze them. Questions on any of that? All right. Bradycardia, not much different from AHA side. In the past, the midazolam used to be the 2 to 4 milligrams. Dr. Newmeyer and I would change that over to the 2 to 5 because most of the midazolams are in 5 milligram vials, and there's no need to waste good medication. Okay. Oop, hold on a second. Got to take a phone call. So again, with the bradycardia guidelines and all that stuff, from the aspect of using midazolam if you need to for your transcutaneous pacing, think about dopamine. Most of the guidelines, epinephrine or norepinephrine, are the medications of choice for blood pressure and all that stuff. But do have in here with the bradycardia, and then also in the aspect when we get down to the spinal shock, dopamine is still the drug of choice and all that stuff. AFib, flutter, from the aspect, have in there the diltiazem and or metoprolol. McGinnis over at Harris Elmore kind of sort of caught with metoprolol when she was going through the guidelines, and hence had that kind of sort of broken apart now. Still having the philosophy, if the patient gets bad enough, giving them a little bit of fentanyl and Versed, and letting them ride the white lightning. EKGs and all that stuff afterwards. SVT, not much is different from the aspect of therapy-wise. Adenosine is still the first drug of choice with diltiazem, and then if they have any problems, giving them the fentanyl Versed and synchronized cardioversion, and then transporting. WW, adenosine is in there. This is the one thing where amiodarone over top of diltiazem instead of the diltiazem and all that stuff. And if they have problems, of course, going down the midazolam fentanyl, like the ACLS algorithms and all that stuff. Pediatrics, not much different. Even though PALS is kind of sort of going away from atropine in the pediatric population, specifically in the PEAs and all that stuff, we still do have it in the guidelines. Their real big thing is pushing epinephrine, push epinephrine, push epinephrine, but do have the atropine. And remember, it's a 0.02 mg per kg with a minimal dose of 0.1. So anyone under the age of 1, which is approximately 10 kilograms, should get a dose of 0.1 milligram of atropine. Tachycardia, not much different from everything else, either wide complex or narrow complex, so very similar to the adult tachycardias and all that stuff. The rest of the guidelines here is just all the AHA stuff, so if you need a reminder of training or review, it's all there. And then into the dead on arrival. Okay, so if they're dead, okay, incompatible with life, decapitation, burns, versus the decomposition, rigor mortis, or the traumatic arrest and asystole on monitor. And then they've been down for longer than 20 minutes, or they have a DNR, DNR CCA. Yep, they're dead. Okay. Now, if they're partially dead or not quite dead, all right, again, continue with your criteria for resuscitations and all that stuff. I'm not dead yet. Yeah. Mighty Python and the Holy Grail. Yep. All right. So on the termination guidelines from the previous, okay, so if they don't meet the DNR and they're not obviously dead, okay, kind of sort of go down the pathway of how do we terminate. So in the blunt traumatic arrest, one of the paramedic and or advanced EMT, your goal is literally getting that patient on the monitor while someone else is doing CPR. Getting them just even fast patches, okay? Is the patient in asystole or not? If they're in asystole, we're done. You're not getting them back. It's less than 0.001% chance of getting that patient back. And a lot of times there's the potential issues or concerns where we're trying to speed things through and one of the other crew members might get injured, especially like things with extrications and all that stuff. Versus actually taking care of a person. All right. On the termination, they've been down for at least 20 minutes. They're non-hypothermic. The ECG either has asystole or the idioventricular standstill, or if you've started resuscitation measures, you've done it at least for 20 minutes with an airway, IVIO. All that stuff in place. And then, of course, the last one is always the appropriate emotional control. Yes, on the island, the potential of moving the patient from one area to another area just to get them out of safety or out of your, get you guys out of harm's way is always a possibility. And that is completely appropriate. Right? If you need to, document, call med control. Usually you guys... For this one, you'll be calling St. Vincent's, explain everything, and the doctor will say, yep, he's dead. DNR, not much has changed on the DNRs. That's still the same thing as the state of Ohio. And then LVADs. I know that there's no one on Put-in Bay, but they do have somebody over at Kelly's Island that has an LVAD. Have you heard anything more, Greg?
Greg's out doing tour with the clinic people, but I had not seen anything more.
Okay. So the potential, though, we might have people come across the island or across the boat that has LVADs. So never a good thing. Just remember that CPR is the last-ditch effort with people with LVADs. Yes, you can still do it. There's going to be two tubes. One tube that goes into the heart, one tube that comes out of the heart. Once you start doing chest compression, guess what happens to the tubes? That's correct. They get pulled out, so they have a bloodbath inside the chest. They die. All right. Questions on cardiac? Anything further? Anything more? All right. All right. So pretty much we'll do tab 3, a little bit of tab 4. Most of tab 5 we'll kind of sort of skip over because it is a redundancy of tab 3, except that it's just the little people. And then the remainder. So the bulk of the information, the bulk of the stuff that you guys will be doing on the island and all that stuff will come into the tab 3 area. The abdominal aortic aneurysm, it's a new one that was added in a year ago, kind of sort of. We've been seeing a lot more of AAAs, and then now even the thoracic dissections. Don't know why, but for some reason just seeing a lot more of this. IVIO access, if they're having a pulsatile mass, they're saying, yes, I have a known aneurysm. You check their feet are cold, they have no pulses in their feet. Then of course consider, dissections and aneurysms and all that stuff. The whole process here is really getting their blood pressure and their heart rate as low as possible. Okay, give them labetalol, give them metoprolol, anything and everything to get their heart rate and their blood pressure low. All right, goal of 90 to 120, even ideally less than that, with a heart rate of 60 to 70. You give them enough medication until they're barely mentating. You guys aren't carrying their cardipine right now, but the helicopter is. And then, of course, any of the pain medications and all that stuff. In the abdominal pain, of course, if it's a known or suspected aneurysm, going to the appropriate guideline. Any signs of dehydration, giving them fluids. Are they complaining of nausea, vomiting, giving them medications and all that stuff. And again, with the advanced EMTs, the PO or sublingual Zofran. Do have in here EKGs. An EMT by the state of Ohio can put on and administer an EKG. So tomorrow, of course, when Tim and Pat come out there, they'll go through the training with all the EMTs on how to do EKG placements and all that stuff. All right, so alcohol intoxication. This guideline was created several years ago specifically for you guys. Is the patient clinically intoxicated? All right. So from the aspect, I drink a margarita, I'm good. I give my wife a margarita, she's on the floor under the table, drooling and all that stuff. All right. So it's not always from the aspect of how much they've had, it's how does the patient look. Always consider spinal mobilization, consider airway if it's bad enough, check the blood sugar if need be. And then from there, does the person have any incapacitating intoxication? Meaning, do they have airway problems? Can they have problems with standing up with minimal assistance? Or are they out there with any potential environmental exposures or traumas or in an unsafe location? If none of that, then from there, do they have any acute illnesses or injuries? You look them over head to toe. There's no blood. There's no bruising. There's no nothing like that. They're not seizing. Okay. Those patients I could really care less with. All right. And we do this all the time. And for those that have not been on the island before is, yes, you're going to be phoning friends. You're going to be transporting, potentially, signing patients off that we do not normally sign off on the mainland. Otherwise, most of the time, a lot of the intoxicated people, they do get the 2-bag rule, and Greg will talk to you guys about that more later. Allergic reactions, this is really unchanged from last year. If they just have the highs, rashes, of course, using your Benadryl. If they're having respiratory problems, in the past, this used to be all green, and it's a blue-green for the specific aspect. If you look at the scope of practice for the state of Ohio for EMTs, if it's medication from your stock, an EMT has to ask for permission. Of course, advanced EMTs, paramedics do not have to ask. You guys can administer appropriately and go from there. Atrovent is the next medication with the first or second dose, and then your IVIM Benadryls if need be, epinephrine, and if you have to, Solumedrol, prednisone, and if it's really bad, of course, getting into doing your epi drips and all that stuff. Questions? In the altered mental status, the only huge major change is going to be on the glucose. Instead of doing the 60 to 400 as in the past, it's now up to 250. So again, IVIO access, give them fluids, check their blood sugar. Sugar's low, give them sugar. If need be, if it's the 60 to 250, think about any other potential problems. If it's a fire, of course, think about carbon monoxide or cyanide toxicity, head traumas, overdoses, seizure, strokes, going down, the whole therapies and all that stuff. Then it's over 250 and they're a known diabetic, of course, giving them IV fluids. And then, of course, the concerns are the DKA and where do they need to go. Do have in here that for the non-transport criteria. So going back to the previous, the treat and release and the refusals. So there's really three classifications, three areas where I'm okay with as a treat and release. So from the aspect of your hypoglycemic patients, when we talk about the respiratory distress that you guys give an albuterol to, and then it's that tased patient that got tased by the police that there's nothing wrong with them and then they're going to jail. Of course, you have your skin, your fall down, your skin, your knees, all that stuff that we don't care about. In the back pain, from the aspect, the same similar with the AAA, in regards to if a person's complaining of upper back pain, one of the things that's taken into consideration is your thoracic dissection. So pain between the shoulder blades, check the blood pressure. The blood pressure's, a 20 millimeter difference. It's, considered, it's a dissection until proven otherwise. So really the same therapies, give them the labetalol, metoprolol, get their blood pressure low, give them pain medications and all that stuff. If it's a trauma, of course, giving them some immobilization if need be, your Valiums or alternative benzos, and then IV fluids and transporting accordingly. Behavioral excited. This is a new guideline. Actually, it's a modified guideline. So if you can see down here, of course, your blood sugars, treat any other potential things, rapid takedown if need be. Okay. Look at the medications. All right. Before it used to be Haldol, Benadryl, and Midazolam, and ketamine was in blue or consider. All right. Ketamine is now becoming the drug of choice for the behavioral excited delirium patients. It's a faster onset, faster, the patients are able to maintain their own airway, and it's better overall. There's some thought and theory that the potential of causing an increase in ICP, which is they've been able to debunk that. We do know that the complications of ketamine, it will increase their blood pressure. It does increase their heart rate, and they do have some vivid dreams and all that stuff. So, who cares? Yeah. So, give them a little bit of Special K, let them calm down, and it's a wonderful thing. I mean, 4 milligrams IM in a minute, minute and a half, they are gone. You own them. and it lasts for the most part, you're about 7 to 10 minutes that they're in a potential state, but they can be calm for anywhere from a half an hour to an hour to an hour and a half, which is, again, it's a wonderful thing. I have had, unfortunately, several occasions where I've given the ketamine and they stopped breathing. They say it's not supposed to happen, but it does potentially happen. Okay, and what do? Intubate. So, dental pain is a new guideline that's added in. So if you suspect any of the jaw pain from a cardiac, of course, getting your EKG. If it's a multi-system trauma, going down that pathway. Any of the bleeding issues, of course, take care of the direct pressure. And then from there, what is about the aspect of what do we do with the tooth? Okay, the tooth. Remember the tooth. All right. If you need to, put it in milk, put it in the save a tooth. The thing that I actually like doing is rinsing it off. Don't scrub it, the root and all that stuff. Kind of sort of figure out where the tooth goes into their mouth. Now, if they're, if they have summer teeth, you might not be able to figure out specifically where it goes. So from there, if you can figure out where the tooth goes, line it back into place, and then push the tooth back into the socket if it's been completely avulsed. Yes, it does hurt a little bit to the patient. I always tell the patients, no, I'm not going to feel a thing. You will feel something, okay? And then push real down hard. From there, the next thing is, as long as the person is not intoxicated and at risk for swallowing the tooth, that's a great thing. Have them bite down on a tongue blade or even a rolled piece of gauze. From there, that does two things. It helps with to stop the bleeding, and the patient doesn't talk. All right. In the dialysis renal failure, new guideline that's added in. Of course, from the aspect of the shunt, bleeding, fistula, and all that stuff, taking care of the bleeding, direct pressure, anything from there. Most of the time, if it's the shunt is bleeding, just one finger and will take care of the problem. All right. So even to having the patient put your finger on the bleeding, it'll stop. If they're having problems with CHF, of course, going to that guideline, cardiac arrest. Going to the PEA, cardiac arrest guideline, and then any of the bleeding or if they're altered, anything like that, checking the blood sugar. If they had dialysis within 4 hours, considering giving them IV fluids. And then the last one, of course, is that patient that missed dialysis. And on EKG, they have peak T waves or they have a wide QRS. Starting them off with albuterol. Look at the dose. It's 10 to 20 milligrams nebulized. Okay? This isn't 1 or 2 treatments. This is 4 to 8 treatments of albuterol. Okay? Just put it in there. The albuterol, what it does, at 10 milligrams, it'll drop their potassium level by about 0.6. And at 20 milligrams, it drops at about 0.95, almost 1 point, which can potentially save a person's life and all that stuff. After that, of course, give them the calcium chloride or calcium gluconate, and that helps stabilize the membranes. And then you give them bicarb until either their T waves decrease or their QRS complex shorten. Okay? How much bicarb? Usually takes 1 to 2 amps, might take 3 or 4. Okay? But you give them enough until everything shortens down. Questions on that?
Joey's our problem child. No, we're good.
Okay. I just hear a lot of laughing and giggling. Epinephrine, not much has changed from the aspect. Tilt the head forward, give them the phenylephrine spray, and then from there, if they're hypotensive, of course, bleeding control, give them IV fluids. Most of the time, if the patient is hypertensive and they're still having bleeding, you got to do something to decrease their the blood pressure and all that stuff. So give them a little bit of midazolam to calm them down if they're anxious. Give them some beta blockers, some nitro, something like that, to bring their blood pressure down. Foreign body, not much different from previous. Just remember that we can no longer call it the Heimlich maneuver. The person that created the Heimlich, once he died, his family has gone through and copyrighted it, and they're now getting royalties. God bless them. They're getting paid for it. In the hypertensive guideline, from the aspect IO, of course, your bilateral blood pressures first. If they need to, give them the IV fluids. If their heart rate's greater than 60 versus under 60, if it's over 60, labetalol is the first drug that we like. Metoprolol, if not. If it's under 60, of course, enalapril and captopril. If you don't have any of that, just give them the nitro. And give them enough nitro until their blood pressure comes down. On the hypertension, of course, the opposite, IVIO. If it's trauma, giving them fluids, 20 ml per kg as needed. If it's non-cardiac, non-trauma, giving them fluids. Consider your norepinephrines and dopamines and all that stuff. Then, of course, if it's a cardiac, from the aspect of your, fluid, if need be, norepinephrines and dopas and all that stuff. Flu, just from the aspect, the biggest is taking care of a flu patient or influenza type stuff. If they're wheezing, giving them the albuterol. Kind of sort of, take into consideration if you're in the back of the ambulance and if they have the influenza or viral syndromes, you might not want them breathing through a nebulizer, okay? If you have to, remember your N95s, put it on yourself, protect yourself, and go from there. Otherwise, if they have nausea, vomiting, using the Zofran, blood sugar, check blood sugar, and all that stuff. Questions, concerns, anything like that thus far? Comments? Nothing? We all good? Okay.
Great.
All right. In the alter mental, the only huge major differences from last year to this year, of course, was just the addition of the Narcan from the EMRs, so they can give the intranasal Narcan. Of course, you guys can still give the IV IO forms of Narcan and all that stuff. From there, beta blockers, of course, giving them glucagon, 5 milligrams, any of the calcium channel blockers. Giving them calcium as needed, CO poisoning, cyanide, amyl nitrate, getting them to a hospital. You guys don't have the hydrofluoric acid, unlike Harris Elmore, but they do have all that stuff. Organophosphates, the Dewey dose atropines, the tricyclates, the Valucarb, and then anything else going from there. And just the rest of the information, talking about all that stuff. The psychiatric patient is a new guideline. If you, it kind of sort of looks, mirrors just the behavioral excited delirium side of it. If the patient is agitated or aggressive, going down the behavioral excited delirium. If they're having an anxiety attack, which, no one ever has an anxiety attack on the island. Consider, your midazolam or any of the alternative benzos. If you need to give them a little bit of Haldol to calm them down. I know that in the past, the medics, you carried Haldol in your pocket, readily accessible and all that stuff. If the patient is depressed or suicidal, consider a mental health hold. I've done a little bit more reading on this, and we have not changed the guidelines. Unfortunately, paramedics, EMS providers are not allowed to sign a pink slip. I thought they were, but unfortunately not, okay? But what you can do, police are allowed. So if you actually look at the ORC, police, doctors, and all that stuff can sign a mental health hold. You guys, of course, can transport and take them from there. So if the patient needs it, again, this goes back to the whole aspect of mental capacity. Do they have mental capacity? If they don't, we can go from there. Contacting med control or having the police officer sign the pink slip. And this is just all the discussions with pink slips and all that stuff. In the respiratory distress, this is kind of sort of similar to your influenza. If they're having CHF, pulmonary edema, going to that guideline. If they're wheezing, giving them your albuterol and Atrovent, CPAP as necessary. How much, what PEEP do we do? Start them off at 5. If you need to, increase up to 10. Titrate for effect. If they're still having problems, the whole using of your epinephrine, prednisone. And if you need to, if it's bad enough, putting them on an epi-drip. Of course, if you're putting someone that's in respiratory distress on an epi-drip, hopefully you've had the patient or you're in the process of intubating the patient. And this is actually, on intubation-wise, ketamine is actually one of the better drugs for a respiratory distress asthma COPD patient. So instead of using etomidate, the ketamine has a little bit of the bronchodilation along with causing a little bit of fluid in the airway, which helps moisten the airway and all that stuff. So take that in consideration. All right. Questions? Do have in here on the other side of the Strider, and yes, I did re-verify the epinephrine 1 to 1,000 dose. It is 5 mLs nebulized. Okay, so you can either, if there's Strider, a little bit of normal saline, or doing your 1 to 1,000 epinephrine, or the racemic epi and all that stuff. Seizure guideline, this was kind of sort of modified this from the aspect of added in the febrile seizure for cooling measures and all that stuff. And then from there, are they having an active seizure? If they're having an active seizure, you give them enough medications until they do one of two things, okay, when it comes to benzos. They either stop seizing or they stop breathing, okay? Once they stop breathing, you intubate them, and then you give them more benzos. All right. Of course, we do have in there the magnesium for the eclampsia or preeclampsia and all that stuff. And as a reminder, they can have had a baby in up to 4 to 6 weeks after pregnancy. They can still be eclamptic, or they can still have seizures. Keppra, of course, is the new medication that's in the guideline. It's the one of several, okay, where Keppra is becoming one of those drugs of choice for a lot of the neurologists. It's 20 milligrams per kilogram, very little side effects. The onset IVs within several minutes, and it lasts up to about 6 to 12 hours, depending on what literature you read and all that stuff. So if they're still continued seizing after medications, give them the Keppra and then go from there. Patient, by the time that they get the Keppra, they should probably be intubated. In the stroke, there's some modifications and changes and all that stuff. So of course, airway management, immobilization, and then from there doing your stroke scales and all that stuff. All right. If it's under 3 hours, the goal is going to be, I know at the top, I have, the emergency things. Ideally, stroke should be no longer than 10 minutes. But do we have in here 20 minutes? Okay? So really limit your on-scene. Ideally, no more than 10. Get the helicopter flying and all that stuff. All right. Head to bed up, NPO, maintain their blood pressure, anything and everything. And then the question is to ask, is the patient a TPA candidate? All right. If it's under 3 hours, I don't care what hospital this patient goes to. Okay? They can fly to any hospital that has the ability to give TPA if it's under 3 hours. So from your guys' perspective, if they're a TPA candidate, it's getting their blood pressure, treating their blood pressure less than 185. If the patient's not a TPA candidate, the literature is actually saying that you can let their blood pressure rise up to 220 before you start treating. All right? We still have a little bit of issues about treating a blood pressure, you know, at 220, or starting to treat blood pressure at 220. So that's why we have in there start treating at 200. Okay. So most of the TPA candidates, if it's over 8 hours, you know, they're definitely outside the window for TPA. Most of the time, if it's over 3 hours, and going from there. All right. Questions on that? All right. Suspected abuse, not much different. Just added in here the aspect of physical abuse, making the MPO, psychological physical abuse, and all that stuff. Document, 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 document. Okay? You guys will probably be called into court if you have some form of physical or sexual abuse. All right? On the syncope, not much different. Orthostatic vital signs, IO, fluids, treatment, check blood sugar, and then, of course, getting the cardiac monitors and all that stuff. Vomiting, diarrhea, pretty much the same as in the abdominal pain, just your different medications, your vomiting for your Zofran, fluids, pain control, and all that stuff. We have added a well person check, and this is kind of sort of just prepping for when we're allowed to do community paramedicine. So you do get that check safety, make sure there's no complaints, check vital signs as necessary. Anything abnormal, of course, recommend transport. Otherwise, have them call back. And the last, we added in most of the pain medications are the exact same. So there's a distracting technique that we used to do with the kids. Ibuprofen, Tylenol for simple things. Do have in here your fentanyl, morphine, Dilaudid. And then ketamine is, of course, a med control for pain medication, all that stuff. We've added in a muscle spasm consideration. So if you have the, you know, your fracture that's the muscle itself is spasming, give them a little bit of Valium or some Versed. And then, of course, your Benadryl for itching or nausea medications. And that's tab 3. Any questions? Nothing? Anything? All right. So just tab 4, simple going through this. We moved OB transport to the beginning. Most of it's load and go situations and all that stuff. In the vaginal bleeding, postpartum hemorrhage, giving them the IV fluids. If they've delivered within 24 hours, hopefully they're not on the island. If they are delivered within 24 hours, that's bad. Otherwise, if they're having problems, norepinephrines and dopas and all that stuff. Okay. Just as a reiteration in the past, still got to do it again. Okay. Internal bimanual vaginal exam is not required or indicated in the field. On the OB emergencies, this is really the aspect: are they having eclampsia, preeclampsia, and then from there are having preterm labor or are in labor. If they're, you know, eclamptic, preeclamptic, of course, using your blood pressure medications, and then MAG and Versed. Okay. If the mother's pregnant and they're seizing, of course, you got to take care of mom, and as before, take care of mom, and she takes care of the parasite. Otherwise, if they're delivering, you know, of course, deliver the baby and go from there. If it's preterm labor, think about using your magnesium sulfate as a tocolytic. Do have in here the fetal delivery. Not much I'm going to talk about this. We all know how to do that from paramedic school. And then your delivery, either your vaginal or the breech presentation. Any of your complications. Talk about your breech presentation versus the prolapse cord. In the prolapse cord, really like to emphasize the aspect, anything and everything, trying to get their knees to their shoulders, and or if you have to put the person in doggy style, that helps the gravity, lifting the head off the cord, anything to protect the cord and all that stuff. Neonatal assessed. And the thing that I'll talk about tomorrow with the BLS crews, most of neonatal resuscitation is a BLS, you know, simple EMT therapy. Unless the patient has meconium aspiration, Most of the stuff is warm, sim, dry. Giving them some oxygen, wait 30 seconds and not having problems, giving them, bagging. And if they're still having problems, of course, doing chest compressions, all right? Question is, where's the ideal place on a neonate to check for heart rate?
Umbilical cord.
Yep, correct. Umbilical cord. If you have to IVIO access, I know a lot of the neonatal nurses, they like doing scalp veins and all that stuff on the kids, and going from there. And that's OB. Any questions on that? All right. Pediatrics, just have the tables, the guidelines, and all that stuff. We do have in here the Broslow, all the Broslow information. If you don't have on your phones, they make a couple good pediatric apps. The major one that I like is called, and I'm blanking out right now. Where is it? Palm PD. I think on the iPhone it costs like $3 or $4. On the Android it's like $1.99. But you literally put the patient's weight in and it tells you everything that you need. Medication dosages and all that stuff. Tube size, intubations, NG tubes, anything and everything. It's a wonderful app. Otherwise, most of the stuff in here, the abdominal pain, all that stuff, it's all the same as the adult allergic reaction, just going to be your medication dosages. That's going to be the only real major differences and all that stuff. As a reminder for your EpiPen, okay, EpiPen Junior, age 8 or 55 pounds. Otherwise, most of the stuff is pretty much the same. In the psychiatric patient for the pediatric, the Haldol will be a med control order. So over 5, or you're 6 to 12, and then over 12 and all that stuff, med control order for that. Otherwise, everything else is pretty much the same as the adult. In the pain-wise, do not have ketamine for the pain and all that stuff. Okay. Environmental bite and venomation, not much has changed from previous. Just the allergic reaction and pain control. Otherwise, can you assess the patient? Does the patient need to go to the hospital and all that stuff? Burn, not much different. Except with the exclusion of the thermal inhalations. Okay, so they're now going, or we changed it over to what's called the modified Parkland formula. So it's doing 2 mLs per kg times percent body surface. So if you have someone that's burned 50%, they weigh 100 kilograms. Okay, that's roughly 10 liters of fluid within 24 hours that this person needs. All right. So for the first half of that, so 5 liters needs to go within the first 8 hours. So if you touch the person at hour number 7, they need roughly 5 liters of fluid within that first hour. Okay? If you get the person at hour number 1, of course, they get 5 liters over 7 or 8 hours. So it really depends on when you touch the person. Otherwise, chemical, irrigating, and all that stuff. Just remember, not all chemicals like water, so be careful and going from there. And then electrical and all that stuff. Have the burns rules of 9s. In the drowning, near drowning, this was kind of sort of broken apart into 3 different pieces. As the person awake and alert, which is kind of sort of what we've done in the past. Encourage the person to go to the hospital, and just remember 4 to 6 hours they have the second drownings, so the person develops the pulmonary edema and all that stuff. If they're awake but altered, consider other things, glucose, Narcan if need be, and then transporting and going from there. And if they're unresponsive, checking for pulse. If they don't have a pulse, doing cardiac arrest. Otherwise, transporting and going from there. Questions on any of that? Simple stuff. Hyperthermia, not much different. We all know how to take care of, hypothermic patients, IV fluids, and treating for seizures and all that stuff. And then hypothermia, pretty much the same from the aspect of, taking care of, your popsicles and all that stuff. All right. In trauma, the trauma guidelines, this is just pretty much the breakdown of majors and minors, and then from there your adult pediatrics and geriatrics. Nothing has really changed from that. From last year's guidelines to this one, the start triage or the jump start triage, it used to be 2 separate guidelines, so kind of sort of pulled it all together into one guideline and going from there. Most of the trauma stuff not going to really talk about, just a couple pieces. We do have on the helicopter and on the island TXA. Has anyone heard of TXA? Okay, perfect. So TXA, or tranexamic acid, is an old medication that has resurfaced for those that have not heard about it, in the aspect of therapies for the trauma patients. All right. So the guideline side of it is, indication-wise, they have to be over 16. They have, of course, the 2 or more markers of hemodynamic instability. So cap refill problems, they're tachycardic. You guys won't be able to assess for hemoglobin. You won't be able to assess for INR. Potentially might in the clinic, but who knows. So they're, systolic pressure, sustained systolic pressure under 90. They remain, tachycardic greater than 110. What you're going to do is going to give a gram over 10 minutes. So it comes in the vial's a 100, or sorry, I'll have to wait. Put the vial, you have to mix it up in a liter or in your 100 ml solution, and then from there, administering and going from there. Abdominal trauma, not much different. Did add in here just vital signs, perfusion, and all that stuff. On the chest trauma, again, vital signs, getting your EKGs, pain control. And the crush injuries, we've added in the aspect of for the concerns for a hyper K or your potassium levels. So again, very similar to the dialysis patients. So if your patient's potentially trapped up to 4 hours, start considering the breakdown of the muscle of the rhabdomyolysis. And therapy for that is, of course, giving them albuterol and then the calcium chloride and bicarb and all that stuff. Eye injuries, not much different from that one in the past. Okay. Head traumas. So over this past January, one of the big things that they kind of sort of talked about was with head traumas and therapies and all that stuff. The aspect, if you have to intubate a patient, make sure that you intubate the patient. Okay, what they were looking at, a lot of the discussion was the number of intubations, looking at all-cause mortality. So if you miss intubation the first time, you increase, it's a 16% increase in mortality. It was a 25 to 28% on a second miss, and if you miss 3 times, all things considered, it was a 49% increase in mortality. All right, so do what you need to do, intubate the patient, pass the tube, and go from there. So the 2 things that kills a head trauma patient, of course, is lack of oxygen, and then, of course, the blood pressure. Multi-system trauma, nothing different there. Musculoskeletal, just remember on amputations, taking care of that. And then obstetrical traumas, taking care of mother, and she takes care of the parasite. Pediatrics, pretty much the same as the adults and all that stuff. Spinal trauma is very similar to the head trauma. Dopamine, of course, is going to be the drug of choice for your hypotensive and bradycardic. And then we get into the police custody. Okay. After last year's incident of me being on the island and getting pepper spray in my face from trying to decontaminate somebody, kind of sort of added pepper spray into the guidelines. Yeah. That was not a fun day. So remove them, irrigate them. I've heard many different ways of trying to get the decontamination and all that stuff. Everything from using milk, whole milk versus 2% milk, to Johnson & Johnson baby shampoo, to Dawn dish soap. I really don't know what works, and go from there. I'd probably recommend the Johnson & Johnson baby shampoo. And then irrigate. If the person has any history of asthma or COPD, of course, observe them for 20 minutes. Yes, by the time you decontaminate them, it's going to be 20 minutes. And then, of course, on the other aspect, on the conducted energy, if they've been tased or anything like that, if they're having any complaints, getting the EKGs and 12 leads and all that stuff. Otherwise, if they're not having any problems, hemorrhage control and barb removal. Just remember that if you're going to remove the barb, have them disconnect the gun from the box first. Okay. Or the other aspect, make sure that you do not grab both barbs at the same time. Yeah, exactly. It's only 50,000 volts. Otherwise, hazmat's the same, and weapons and mass destruction is the same. Okay. Is Greg back?
Yeah, he just stepped outside a second ago.
Okay. All right. I'll talk with him on a later thing then. All right. So, what do I need to know about, or what do the medical directors? Okay. So, if you intubate somebody, you needle decompress them, you put an IO in. If you use your guys' auto pulse, okay, we want to know about it. With the EMS charts, we have not done it in the past, but there is a way of doing special procedures and all that stuff, and I'm going to talk with Greg about this. It'll actually, if you do certain things, it will actually send an email to us that you've done that. It's an auto notification and all that stuff. If you have to send an email to either myself or Dr. Newmeyer or Dr. White, in the subject heading, okay, put in there confidential peer review information protected by Ohio Law 4765.12. Okay. Again, this now makes the email confidential peer review. What does that mean? Rule number 1. Okay. Or from the other aspect, if you piss somebody off or someone pisses you off, again, let us know about it. It's easier for us to be proactive versus reactive. All right. Any questions on that? All right. From here, the only other couple things just to kind of sort of go through. One, just for the airway management, and specifically I want to get down into the failed airways. All right. As a reminder, okay, 2 attempts to intubate. If you can't intubate, have someone else attempt. No more than 3. Okay. If you miss 3 times at intubations, go to something else. Okay. Either using your blind insertion devices, your King Airways. You guys will be practicing with, the retrograde intubations, doing a digital intubation if you have to. All right. Anything and everything. If you can get by with just simple BVM with an oral airway and a nasopharyngeal, great. Just do that, okay? You don't always have to intubate. Even if we start attempting to intubate, back off. If you can ventilate them, ventilate them. All right? And finally, okay, nobody dies without an airway. If you have to cut them, cut them. All right? Do a surgical airway. One of my residents a couple of years ago kind of sort of taught me the trick that I like, that after doing the surgical crike or the surgical airway, he always put a bougie into the airway or into the hole. That way you always know where the airway is. And I've been doing that ever since. So, and then from there, the final aspect, of course, you guys will talk about the medication-assisted intubations. All paramedics over the next couple weeks will be tested on this guideline. Yes, I'm getting a little bit more stringent on this. I really want you guys to make sure that you know 3 o'clock in the morning, all the medications, indications, contraindications, and all that stuff. As a reminder, once you push succinylcholine, okay, who owns the airway? Okay, exactly. All right, you own the airway. So be careful and all that stuff. If you don't feel comfortable pushing the succinylcholine, don't push it. And from there, the last piece that I just want to kind of sort of talk about is going to be the selective spinal mobilization. Find it. IOs, IVs. Do we have in here rehab? Have the Zoll stuff in here. Influenza. Mucosal atomizer devices in here. Nerve agents, organophosphate poisoning, sedation, restraints, trauma, amputation, dental, pelvic binder. Okay, here it is. All right. So again, on the website, go to www.nwoems.com, left-hand side under the guideline review. Okay. There will be at the bottom of that the selective spinal mobilization. It's an hour long. Okay. Yes, we will give you guys CE credit for doing that. Okay. It'll give you an extra hour of trauma CE. If you need it, great. If you don't need it, okay. Pat you on the back. Have a good day. All right. So really, from the aspect of consider mobilization, consider the mechanism of injury. All right. Yes, people die with the golf carts. Surfing on top of the golf cart and being thrown off can cause neck problems. From there, is the patient able to ambulate? Okay. If they can ambulate, they don't need a backboard. Right? You don't have to walk them over to the stretcher with the backboard laying on the stretcher and have them lay down on it. We no longer have to do these standing takedowns. Okay? From there, the next piece on the right-hand side is all based upon literature, specifically the Nexus and the Canadian C-spine rules. And again, that's all in the video. If the question to ask while someone is maintaining inline stabilization, are they under 2 or over 65? If they are, we cannot use these guidelines. Okay? From there, is the person, do they have reliable communication skills? If you're talking English and they're talking Arabic, guess what? There's not a reliable communication there. From the next piece is really, it's a 5-step process, and the mnemonic that we use or that we teach the residents and all that stuff is NSAID, non-steroidal anti-inflammatory drug. That's what ibuprofen and that's what aspirin is. Okay, so someone meets or actually doesn't meet these criteria, okay, meaning that they don't need to be immobilized. That's all that I give them. Okay, here's some ibuprofen. No, you cannot have any Dilaudid. Have a good day. All right. So the first one is the neuro exam. Are they having any focal weakness or numbness? All right. So what you do is you have them extend their arms out, cock their wrist backs, and spread their fingers apart. And what you do is you test motor. Push on their fingers, push on their arms as long as they can resist. From there, you have them step on the gas pedal, pull up on their toes. All right? And then the final 2 pieces with that is sensation. Touch them from their feet all the way up to their head. Can they feel it? Are they having, any differences? And then the last thing is to ask them, are they having any numbness or tingling? If they have any problems at all with that, the patient says, yes, I'm numb in my finger. Do you have a history of numbness in your finger? No. Okay, that is a neurologic finding, and you put them in a cervical collar. Of course, from there, the spinal exam, are they having any midline spinal tenderness? If they do, point tenderness, that area needs to be immobilized. If it's in the cervical region, put them in a collar. If it's not in the cervical region, but it's the lumbar, yes, they might need a CAD or a longboard or something like that. Are they altered? Are they intoxicated? Okay? If they are, at least put them in a cervical collar at minimum. And then the last piece is the distracting injuries. What they say that this is kind of sort of a long bone fracture, a femur fracture, a humeral fracture. Do they break their sternum? Or are they having, bruising in the abdomen or something like that? Something that kind of sort of takes their mind off the spine. Dr. Mori, who taught me how to do this, what he would do is he actually comes up and he pinches the patient's neck. If the patient says, ow, don't do that, in his opinion, he thinks that the patient does not have any distracting injuries. Okay? So if they have any of those symptoms or syndromes, at least minimal, put them in a cervical collar. That's all that matters. Okay? If you can get them on a backboard, if they require it, great. If they don't, go from there. So what happens, or the question is really, okay, we have the combative patient, okay? And we've all seen this before. You've had that patient, you put a cervical collar on, they take it off. You put it on, they take it off again. They're shaking their head, they're fighting you. What do? Okay? Stop, okay? Don't do anything, let them be, okay? If you can coach them to get on the stretcher, get them on the stretcher, and then they will splint themselves enough, okay? From there, what do you guys need to do?
Document.
Yes. Document, document, document. Document why you did not put a cervical collar on. Do not document, okay, the aspect, well, the patient was cleared by, selective spinal mobilization. No, the patient's intoxicated. You can't clear them, okay? Just put patients at risk, was at harm, combative, kept removing the cervical collar, and the best patients of the patient, we removed it. All right? And then, of course, notify and go from there. All right? In the last two tabs is the aspect of your digital blocks, if you need to do a digital block to get a fish nail or fish hook removed. Ideally now, with them having the clinic, the potential of us having to do this is going to be decreasing all that stuff. And then tab 9 is just the medication tab.